Okay, we're gonna go ahead and get started then. So thank you for to everybody for joining us. So this presentation is going to be on geriatric mood disorders. My name is Dr. Samuel Traverso. I'm a second-year resident at Amita LaGrange Family Medicine. I'm accompanied by my two attendings, Dr. Layne Phillips and Dr. Sarah K. Welch, who will be coming into the presentation a little later on. So let's go ahead and get started. So as far as disclosures, we have none at this time. We have nothing at this time to disclose. Goals for this presentation are that by the end, you'll be able to understand the screening tools and diagnosis of mood disorders in the geriatric population, understand how to make assessments of these geriatric patients, how to manage them with medication and non-medication treatments, and how to use the Beers criteria as well as manage their likely polypharmacy in this population. Mood disorders in the geriatric population is it's a really important topic to discuss. The geriatric population as a whole tends to have abnormal presentations of diseases. So it's really important to focus on this population when you're talking about mood disorders. In order to adequately diagnose and treat these patients, it's really important to understand these screenings and how the geriatric population will present. It's also important to understand kind of what the patient's goals are when it comes to care and how to balance that with what family wants and other types of things like that. So as far as significance goes, mood disorders tend to be underdiagnosed and undertreated in general, but more so in the geriatric population. Usually this is due to fragmented or inadequate systems of care. Sometimes residential or other facilities will not have the right training, the right staff to really recognize and treat these patients appropriately. And when these things are left untreated, they can lead to worsening of chronic diseases, decreased quality of life in general. So it's really important to kind of figure these out, what's going on, and make sure that they're properly treated. Like I said before, prevalence is higher than in the general population. It's between 8 and 16%. However, if those geriatric patients have a chronic disease, which most do, that prevalence can go all the way up to 50%. If a nursing home resident can have anywhere between 25 to 50% prevalence, usually higher in women. The suicide risk as well is about double that of non-geriatric patients. And like I said before, the symptoms of the depression can be masked by things such as old age, medication side effects. So it's really, it's really important to figure out what is just their normal presentation, what their baseline is, and assess for any sort of changes or any sort of meaningful differences. So obviously this is not an easy thing to do. There are lots of challenges that come with it. Many geriatric patients tend to either live alone or they have very limited oversight, and usually they don't have 24-hour care. Given their cognitive difficulties, they can have issues with managing their medicine, taking too much of their medicine, multiple medications having varying effects. If there are any side effects from their medications, they are more likely to experience them compared to the general population. As people get older, they tend to rely more on Medicare and Medicaid, so there can be issues with cost. And there's also the issue of family dynamics and how the family will manage symptoms, what the family says about the patient's general day-to-day life, and what their opinion is of what their treatment should be. So those can all be difficulties that can come about when we're trying to determine if a patient has some sort of mood disorder. In order to really assess the patient, we have to do a psychosocial geriatric assessment, and there's 3 different areas for that. So we have to assess their cognitive ability, their affect, and their functional needs. So as far as their cognition goes, it's important to assess this given how high of a prevalence there is in dementia in this population, with their affect, what their emotional tone is, and then their functional needs, kind of how they're able to do their daily activities of normal living, cooking, bathing, everything that goes into their normal life. It's important to kind of get a baseline for all of these different faculties so that if patients start developing changes in these fields, it's quick to notice based on their difference from their baseline and can make adjustments to either medications or further management quickly. And usually this assessment is done by a comprehensive team, and if done, will increase the likelihood of a patient being alive in their homes 12 months after hospitalization. So it's not something that we necessarily want to overlook. It's good to have this baseline to kind of make that diagnosis in this population. So the core components of the assessment, like I said, is done with a multidisciplinary team. It's usually gathering info on kind of what the actual screenings and tests have shown about the patients, a discussion between multiple different specialties, coordination with management, figuring out kind of what medications are going to treat this patient appropriately, and really implementing and monitoring the plan for changes that might occur or might need to be made based on the patient's reaction. And it's always important to make sure that we continue to look at their management so that if changes need to be made, they can be made quickly and not have the patient continue on an ineffective treatment regimen. So as far as outpatient goes, the first thing to do is always to perform assessments over a series of clinical visits. You want to choose maybe one domain to focus on at that visit, and really focus on that. And then as you see them more often and you get a better idea of their baseline, you can build that into what your threshold is for assessing changes in them. So things you want to look for: if they have any increased falls, if they're complaining of things like urinary incontinence, and then you want to do a mood disorder screening, which we'll go into a little bit more in detail as we go through the presentation. So at a Medicare annual wellness visit, you want to include a depression screening. That could be your PHQ-2. If it's positive, a PHQ-9. There's a geriatric depression scale. It requires a cognitive assessment. You can do a mini cog, and if you need to, follow up with the Montreal cognitive assessment, all to kind of assess their three different areas: their cognition, their functionality, all of that. So when it comes to your annual wellness visit, there are issues when it comes to the geriatric population. First and foremost, a good percentage of them tend to not be able to drive. So there are issues with getting to your visits on time appropriately. We don't want to have patients who shouldn't be driving be coming to these visits by themselves. We have to arrange for transportation of some kind or see them in whatever facility that they're in. There are issues with abuse, substance abuse, alcohol abuse. Sometimes that's related to the patient themselves, their current life situations, whether or not they're isolated from people around them. It can be related to their family relationships and how their family interacts with them, how they interact with their family. And something that we don't talk about a lot, but is very prevalent, are sexual dysfunctions as well, issues with relationships, whether that's geriatric patients who are married or who are engaging in sexual activity. It's something that can definitely shine light on how they're doing and if they're at their functional baseline. Other things that can present in a geriatric patient that can make doing the annual wellness visit a little bit difficult is if they have urinary incontinence, sensory deficits, cognitive impairments. Those can all make it a little bit difficult to truly assess what their functioning is. So as far as diagnoses go, you have your major depressive, depending on timing, your acute stress disorder versus your PTSD. There's bereavement, dementia, depending on their presentation, vascular depression or other abnormal brain changes. Geriatric patients tend to be on a lot of medications. There can be medication side effects. They also tend to present with a lot more somatic diseases, which can make determining what is a physical symptom of a somatic disease versus what is a physical symptom of a mood disorder a little bit difficult to figure out. But that's all part of the differential, and that's what a lot of these screening tools are for. So as far as anxiety goes, we have two really great screening tools. There's the GAD-7, or the Generalized Anxiety Disorder 7-item scale. There's also the Hospital Anxiety and Depression Scale. And I'm going to go into a little bit more detail on each of those. So the GAD-7 looks like this, as you can see it on the screen. It asks about feeling nervous, worrying, caring too much about things, being able to relax, restlessness, being afraid that something would happen. If you get a score of, if the patient gets a score of 10 or more on this, that means that there's enough, a high enough score to do a further assessment and really delve into, does this patient suffer from anxiety? Is it causing issues in their life? And how can we go about managing it? This screening test is actually pretty, it's got an 89% sensitivity and 82% specificity. There's great ease of access. It's quick, it's cheap, it's effective, and it really should be part of the screening assessment. It's a very good screening tool. The second one for anxiety is our Hospital Anxiety and Depression Scale, or our HADS. As you can see here, it does both depression and anxiety. These are scored separately. A score of less than 7 is negative, 8 to 10 is mild, 11 to 14 is moderate, and after that, it's considered severe, either anxiety or depression. The sensitivity and specificity of this is about 80%. Similar to the GAD-7, it's very simple, it's fast, it's easy. This has been used in hospitals to assess. Examples that I was noticing was hospitals can use this on patients who have recurrent chest pain due to anxiety, and they can use this to assess if they keep having this chest pain, if it's due to the anxiety, or if they need to keep working that chest pain up. So in certain circumstances, this can be an invaluable screening tool as well. So as far as depression screening goes, we have the PHQ-9, which is pretty standard. There's the Beck's Depression Inventory, and specifically a geriatric depression scale. With the geriatric population and depression, it's important to note that you should expect an atypical presentation. Something that you'll notice in a geriatric depressed patient is that if you ask them questions, they'll respond with things like, I don't know, I'm not sure, compared to maybe a similar presentation, but the patient suffering from dementia. Usually that patient will make things up if you ask them questions. So instead of saying, I don't know, they'll say, oh, of course I did that. Or yes, that's definitely true. So it's important to kind of be able to distinguish between the two when you're screening for depression. With the geriatric population, it's important to focus on those physical symptoms over emotional, since those tend to be the ones that present more, and they're a little bit more objective than the emotional ones, which can be related to a plethora of other reasons. So things that we'll notice maybe declining in their ability to perform their activities of daily living, if they tend to use the hospital system or the health system in general more clinic visits, more trips to the emergency room for symptoms that are related to possibly their depression. It's important to listen to the family. The family tends to, if they're around, spend time with the patient and they really have that close connection. So they sometimes will be the first ones to report that things are happening. Patients can experience weight loss. They can experience decrease in compliance with their chronic medications or a worsening of their chronic conditions. So those are all things that in a geriatric person, if noted, would be concerning and it would be important to do a depression screening at that time. Other things that you'll notice, they'll say they're feeling bad. They'll be preoccupied with their bodily functions. They'll have struggles doing their executive functioning tasks. They can have apathy. Occasionally, you'll see hallucinations and delusions, but it's a lot of the physical attributes that you'll notice. So the first one is widely used. It's quick. It's the PHQ-9. It has a sensitivity and specificity of 88%. Between 1 and 4 is minimal depression. All the way up to more than 20 is severe depression. It's a very great tool. We use it in our general population, specifically here, but it's great at the geriatric population as well. This is the geriatric depression scale, very similar specifically for the geriatric population. There is a 15-question version that is shorter. This is great in the geriatric population. I would recommend this specifically if you're doing it on a geriatric patient. As well, another tool is Beck's Depression Inventory. If this is another source, if you wanted to do further depression screenings, if you did not want to use the other two, just as sensitive and specific as the other two. So this is another option for you if this is what you would like to use. So going into a suicide in the geriatric population, this group tends to have double the rate of completed suicides of the general population. So it's really important to hone in on this when you're doing your wellness exams or when you're screening them for depression. It tends to predominate in men. Risk factors, things that would make sense: death of a loved one, living alone, lack of a confidant, having a lot of pain, stressful life events, and specifically if they have access to a firearm, that as well increases their risk. So it's good to ask those questions: is there a firearm in the house? Because that can have you be a little bit more cautious if they're presenting with depressive symptoms. And it's important that the last line on here is probably the most important on this slide, is that asking does not increase suicide risk. Okay, so it's better to ask and have your screening be negative than to not ask and have something terrible happen. So you can screen the patients and make sure you ask them. It's not going to increase their risk of doing anything, but it may help prevent something like this from happening. So we have these suicide risk assessment. Anyone at risk for suicide, they have a history of mood disorder, a positive screening tool for mood disorder, or some suspicious comments during their exam is when you would want to start thinking of, okay, do I need to look into this further? Do I need to kind of escalate the situation? So it's always good to have a plan in your clinic, have resources for people if needed. So this is the ASQ, the Ask Suicide Screening Questionnaire. This is something you can use in your clinic if you wanted to screen for suicidality in your patients. And then as well, it's good to screen for patients, screen for their sleep cycles and how they're doing. If they have untreated insomnia, that can also present with anxiety, depressive symptoms, or that can be related to their anxiety and depression. It's hard in this population to treat them appropriately. Most of the Z drugs that we're aware of are not recommended. They can increase the risk of dementia, increase the risk of falls. And as we get older, our sleep tends to become more difficult. Our sleep cycles become a little bit more deranged. Our sleep maintenance tends to gradually worsen as we get older. And insurance is usually an issue as well when it comes to sleep aids if you're over 65. So it's a great part of screening for mood disorders because it can be related to them, but it could also be in and of itself an issue just based on their age. So it's important to kind of differentiate those two. And I'm going to turn it over to my attending, Dr. Layne Phillips.
All right, this section that we're going to start here is going to be more of a pharmacology section. I'm going to just say a few words more about that sleep problem. Those sleep medications are a huge issue and are often interfering with our treatment, and sometimes they are the main contributing factor to people having problems with anxiety, depression, and those issues worsening. When we mention that there's insurance problems, not only is there insurance problems with the newer medications that are typically $300 to $400, but they're also typically sometimes requiring prior auths or just not even covering some of the disease drugs that these patients may have taken forever. If a patient is taking Ambien or Zolpidem for years and years and years chronically, if you suddenly stop them at 65 because the insurance says that it's not a medicine to use, they are not going to be able to sleep, and they're probably not going to be very satisfied with almost any other option. This is extremely difficult to get people off of, and usually it means slow taper is going to be the only thing that you're going to be able to convince the patient to do. Also be aware that with Zolpidem and specifically, I see a lot of women coming in on it at doses that are higher than they should be. Most people do not know that the dose for women, it should be half the maximal dose for men. So it's usually 5 milligrams instead of 10 if we're talking the immediate releases. So if someone comes in and they're only getting 2 hours of sleep, you're going to have to address that as well as addressing the other issues with depression and anxiety. And you might want to focus on doing one thing at a time. For our anxiety medications, you do have a lot of options, and we will talk about TCAs as well. I know that they're not on this list for both anxiety and depression, but in general, these are kind of in our order of preference, although you do have a lot of leeway in how you want to start this, although SSRIs typically are our first lines. I don't have a specific slide on it, but I will also just briefly mention that serotonin modulators, specifically vortioxetine, also known as Trintellix, is not indicated for anxiety, and I usually only see it in people who have mixed depression and anxiety. So I wouldn't use that as a first, second, or even third line medication for anxiety, unless they also have a lot of depressive symptoms as well. We will talk a little bit more about all these in these future slides. And our depression medication really isn't that much different. We do have the NDRIs in this category, the norepidopamine reuptake inhibitor, and technically you can even use amphetamines, again, something else we're going to talk about on another slide, but you have a lot of different tools in the toolbox here. Unfortunately, with most of these medicines and most of the studies that we're talking about are specifically talking about SSRIs, antidepressant use in the geriatric population can cause a small increase in all-cause mortality, even considering other variables. This is a big meta-analysis that I believe was in the Journal of Clinical Neurology, and if you want, you can take a look at that in our recording, or we can send you the actual link to the article. But even though there is a small increase in mortality, there's definitely a huge benefit in quality of life, and we still are always going to be worried about making sure our patients aren't going to be suicidal, that they're still being social, enjoying life. And we know that if someone remains depressed, it will affect their other comorbidities as well. People that are treated usually are much more compliant with all of their medications. For some people, the fact that they're on so many medications to begin with is often their main reason that they're so depressed. They used to view themselves as a healthy person, and now they're a sick person. And if we can at least make them feel a little bit better and maybe kind of flip the script and making them think that, you know, they're someone who's managing their conditions well and their health is in their control, they're usually a bit more compliant. We all know that geriatric patients are generally more susceptible to almost every side effect of every medication, just like they present with atypical depression. They're also more likely to get the unusual side effects, even if you almost never see it in any other groups. We like to kind of think of this with the same rule that we use for pediatrics. With almost all of our medications, it's going to be start low and go slow. As far as which SSRI you want to pick, if you're going to choose one, as they usually are a first line for both anxiety and depression, you really don't have to specifically choose any one of them. We have a lot of meta-analyses that basically show that a lot of this is probably placebo effect. There's not one that is purely superior to any other SSRI. Sometimes we try to use the ones that have, we'll say, a little bit more of a side effect to our benefit. So let's say that somebody is having problem sleep. Some of our medications tend to be a little bit more sedating to most people than others. Maybe that's the one we would pick. I'll often ask them, have you ever been on them before? Has anyone in your family been on them before? Because patient expectations make a huge difference. If a family member had an absolutely terrible experience with sertraline, you're not going to want to put them on sertraline because they are much more likely to not take it, experience side effects if they are already very fearful of the medication. So try to see if you can avoid repeating past mistakes as well. If they were on something 5 years ago that didn't work, you have so many other options that you really shouldn't have to revisit those as well. I'm not going to read off all of our side effects for you, but I do just want to make a special mention that we typically avoid sertraline in people that have GI side effects or sexual dysfunction because it tends to have the worst of those. Since fluoxetine tends to be our most commonly prescribed, just be aware that that is the most activating, and you're not really going to want to use that in people who are already having a problem sleeping. Paroxetine, also I have special mention in that this tends to be one of the hardest ones to get off of and has the most discontinuation side effects of any SSRI. So if you're going to put someone on that, they need to know they can't just suddenly stop it. Geriatrics are much more likely to have all withdrawal side effects, and paroxetine is one of the worst in all ages. The side effects that we're going to be most concerned with, they can happen in any age, but we already have problems with geriatrics having hyponatremia at baseline, QT prolongation from their other medical conditions and the other medicines they need. The conduction system in the heart is more prone to problems, and they may be falling for a whole bunch of reasons. This tends to make it worse. The common side effects that we're used to with SSRIs, all of those on the bottom, we're used to seeing those, but I typically don't see younger people get much of the anticholinergic effects besides dry mouth. The GI bleeding thing is something that you need to watch out for because with other medicines that are likely to cause GI bleeding, let's say they're on aspirin, SSRIs by themselves aren't a huge risk, but serotonin does have a place in the acidity of the stomach, and so it can predispose them. This is usually a multifactorial thing. So they're on aspirin or they're taking other medication that's irritating to the stomach, and it can make them more likely to bleed. Same thing, they're more likely to bleed if they already have diverticulosis. Now you put them on an SSRI. With the cytochrome P450 things, this is something that becomes increasingly hard to predict as you get on medicines number 4, 5, 6, for a whole bunch of reasons, not just other mental health medications, but medications for their heart, their blood pressure. This is kind of hard to keep track of. Luckily, most of our EMRs are trying to at least assist us in our polypharmacy minimization. Our SNRI group is usually going to be reserved for people that are having the primary symptom of depression and not anxiety, although you can use SNRIs in both. Because they are a little bit more activating, a lot of clinicians will choose to use them as a second line for anxiety. Although I have plenty of patients who that is the only thing they're on for anxiety and they feel that it works very well. Venlafaxine in particular, though, is another medicine like paroxetine that I notice people have a hard time coming off of if they've been on it for a while. Be aware that you have extended release versions and immediate release. And although there's the worry that you are going to, we'll say, overdo it by giving them an extended release, and maybe it's going to be a dose that's too high for them. The downside to doing our immediate release is that the more times people have to take medication a day, the more likely they are to have medication errors, taking the wrong medicine twice, forgetting to take it. So it's probably best to see if you can still start low with the extended release at the lowest possible dose. Try to keep it easy for people. Duloxetine we tend to also pick for people that are having chronic pain as part of the reason they might be depressed to some degree. I am not really recommending that anyone use TCAs for their antidepressive effects. There is just simply way too many side effects, and the side effects tend to be much more severe and dangerous than the ones we're used to with SSRIs. In particular, the QT prolongation can be something that a lot of us don't think of. We don't realize that when you're already on 3 medicines that all just prolong the QT a little bit, that all it can take is giving them that azithromycin Z-Pak one day over the phone, and that could be the thing that causes them to go into an arrhythmia. So if you have someone on TCAs for depression or anxiety, odds are they probably came to you on it because that's what they've been on for years. And I would recommend not increasing the dose if they feel they need more. And I would recommend not starting people on these because we just have better medication out there now. It's also somewhat unpredictable in how it's going to affect their blood pressure. And regardless of whether it's raising their blood pressure or not, this is another medicine that can cause orthostatic hypotension. And this is my big list of things I hate prescribing to almost anyone, but in geriatrics, even more so. The memory problems that come with long-term use of benzodiazepines are just more of a problem in geriatrics, as the fall risk. And although the mantra of start low and go slow, you'd think, oh, well, alprazolam or Xanax doesn't last that long. The shorter they last, the more likely they are to build this psychological dependence of it hits them really fast and then they crash fast. That builds the psychological dependence of I'm anxious or depressed, I need to take a pill. Then it wears off, I need to take a pill. So if I have to use something long-term, a low-dose clonazepam is usually preferred. Things like diazepam have a half-life that is simply too long. I would prefer, if you're going to use anything, you use clonazepam at low doses, or if they only rarely need to take something episodically for things like panic attacks, then alprazolam or lorazepam in small doses is probably okay too, but try to avoid scheduling them at high doses of any benzo. And if they're already on it, try to see if you can taper them off. Just like with those people coming to us on the Ambien or the Zolpidem, this is something that when they come to you and they've already been taking it for years, they can feel it works fast, and they're very unlikely to be as satisfied with switching to just an SSRI alone. And so you're probably going to have to make this a long-term goal. Suddenly cutting someone off on their benzodiazepine that they've been taking for 25 years is usually going to go poorly. I know a lot of clinicians are afraid of a seizure risk that is still very, very minuscule unless they are taking many milligrams repeatedly throughout the day. So it's usually more of a patient compliance, patient satisfaction type of thing. So you don't have to fix this all overnight. This is going to take some time, and they may never be able to entirely get off benzodiazepines, but at least you may be able to reduce their dose if you're gradually and slowly weaning over a long period of time. Buspirone is a nice medication that you can use as a monotherapy, but it's also often used as an adjunct therapy for anxiety. This is a medicine that, unlike the benzodiazepines, has a profile that's more like the SSRIs in that it takes about 4 weeks for the full effect to build. Unfortunately, the side effects of this medication end up being some of the same things we're already concerned about: dizziness, lightheadedness. I've had some people get orthostatic hypotension. And if you're using it with an SSRI, it oddly enough still can increase the risk of serotonin syndrome, just like any other SSRI can, even though it's not directly an SSRI. At least this medication is cheap, and you can do it as a BID or TID dosing. Unfortunately, we have all those problems that come with having to remember to take it 2 or 3 times a day. Somewhat controversial, and definitely not something I usually think of people thinking about as a depression medicine, but stimulants, specifically very low doses of methylphenidate, do have some good evidence in geriatric depression and also for cancer-related fatigue and depression. This is something that if we are going to use it, we usually keep it extremely low at like 5 milligrams once or twice a day. It really helps with that anhedonia, the catatonic, don't want to do anything type of patients. And at these doses, it is very unlikely to cause appetite suppression, very unlikely to cause that sleep disturbance, or really even cause heart problems and other things like that. It's the high doses or the doses that we use for other adults for things like mixed amphetamines, Adderall, modafinil or armodafinil. Those are the things that tend to cause the typical, somewhat scary side effects and interactions that we want to avoid. So I'm okay with using this at low doses, but try to avoid using any higher dose stimulants of just about any kind. All right, and just in general, make sure that we're going to have an entire section on polypharmacy. I'm not going to talk about that. The biggest thing on this slide, besides making sure you've got the right dose and duration, and in that you need to make sure that these medications, if they have liver problems, if they have kidney problems, that you make sure you double check these medications, how they're metabolized, to make sure that you are using the right dose or duration for those issues. But the main thing we want to talk about is that you need to make sure that you're not giving up too soon. If somebody's patient with me, I can almost guarantee that we will find medication that works for them. But since each medicine that we use usually takes about 4 to 6 weeks to really, make an adequate time to see if it worked, we have to make sure that we as physicians are not giving up too soon and our patients aren't giving up too soon. We're going to talk just a little bit about pharmacogenomics, and this is something that has fairly limited utility, but you probably should know that it exists. Some patients may start to ask you about it. The main test that's out there that I've used so far is called GeneSights. They have a psychotropic panel. This is basically a cheek swab that's done in office and sent by mail to the lab, and then they give you a little report. I'm mentioning this also because although a lot of new fancy things are not covered by Medicare, this specific test is, as long as they have major depressive disorder and have failed one agent. It is not currently, as far as I know, approved for any other purpose and not for anxiety alone either. It'll give you one of these fancy reports that looks nice, but as nice as this report looks, it really doesn't actually have that much value. The green section on the left here does not mean to use these medications. It also doesn't mean that a red medication is bad. That's kind of how patients will interpret it when they get this, but every single one of these numbers in these categories represents a footnote that could mean a whole bunch of different things. One footnote may say that this medication's fine, but because of one of the genes we have that check for metabolism, they might need a higher dose or a lower dose. Then there's a few of them that say, based on our gene testing, the mechanism of action might not work, and some of them that say they're likely to have more side effects. So we have plenty of these that come back when we do them, and the patient's been on, let's say, Paxil or paroxetine for 20 years, that's worked great for them, and it's in the red zone. Now they're wondering if they need to be taken off the medicine. So the main utility for us is actually when we have patients that are extremely hesitant to start new medicine, or they had a medication that had really bad side effects and now they're avoiding all pharmacotherapy. Sometimes we'll have them do this, and it may give the patient and sometimes the clinician a little bit more confidence when we're choosing the next agent. But this by itself does not choose our next line, and I wouldn't be jumping to do it on most of my patients. It's usually on patients who not only have failed one medicine, but who have failed many medications and are very hesitant to try anything else. Our next, we still have a few more topics to talk about. I'm going to give this to Dr. Welch, who still has a couple of big things to show you.
Thank you. Hi, I'm Dr. Welch. I'm one of the faculty here with Dr. Phillips and Dr. Traverso, and one of the previous BFEF graduates. So I'm going to start talking about polypharmacy. It's actually one of my favorite topics, so I'm going to try to talk not so quickly, because at least once a week I get excited about something and one of my geriatric patients yells at me for speaking too quickly. So here we are. So polypharmacy is a big issue. There was a fabulous talk yesterday in the CPU series by, I cannot remember their names. I wrote it down and now I forgot their names, but they did a great job. But this is specifically regarding dealing with psychopharmacology and depression and anxiety meds. Now, polypharmacy is classified as being on at least 5 medications, which is 91% of nursing home patients. So quite a population there. It can happen in younger patients, but more commonly it happens in geriatric. Quite frankly, they've had a longer time to collect a few medical conditions along the way, and time is opportunity. It is increased if you have a chronic mental health condition. This does increase your risk of polypharmacy. And having more than 4 medications, which is a lot of our patients, increases the risk of falls, independent types of medication, independent of the type of medication. So just having 4, it doesn't matter specifically what the medications are, even that alone increases your risk, although certain types of medications obviously increase your risk even farther. It decreases the quality of life for these patients, and it does increase their mortality, how frail the patients are, inappropriate medication use, poor compliance. It also has an impact on healthcare and on us as providers. It decreases physician functionality and productivity. Obviously, we have more medications to manage, so more, it's going to slow us down that way, and increases our likelihood of making a medication error. As one of my mentors likes to favorite things to say, he's a geriatrician, and he goes, would you stop touching? Just stop messing with the patient. Sometimes that really is the best medicine we can do is nothing, or taking things off, less medicine. All right. So the concept of polypharmacy management is that just keep in mind many medications can cause or worsen depression, beta blockers, opioids, antihypertensives, anti-Parkinsonian medications. Although I will tell you, I cannot keep up on antineoplastics, especially up to date, and I are great friends for a reason. Alcohol, substance abuse, this also increases your medication side effects. All right, start, stop. These are assessment tools. They can be used to whether or not you should consider stopping a medication, or on the flip side, can you safely start the medication? Would you mind handing me my phone? Because I don't have a timer or a watch on here. Thanks. So the thing is, limitations with it is that it does not take into mind the complexity of the patients, and sometimes patients are more complex. Sometimes you have to do the medication. That's just where you're at. Now, the stop use is a tool to identify potentially inappropriate medications that you should consider discontinuing, and to look for adjustments on medications a patient may already be on. Okay, do they have liver failure? Do they have kidney failure? What is it we need to be adapting for? Make sure we don't have med duplications, and limit our interactions with certain medications. Now, the start can actually be used to what medications can be started safely. So alert to the right treatment. Using these tools does significantly improve medical appropriateness and what we're using. All right, now the top 10, this is the list of medications that we should be considering if it's appropriate, especially number 1, long-term use of benzodiazepine. There's a reason Dr. Phillips hit that so hard there. It's a big deal. Also inappropriate psych medications, TCAs, if you're using them, the patient has, that's a little better, dementia, glaucoma, cardiac conduction disorders, SSRIs, that's on the list for psychiatric and neurology meds because they're classified into different categories, is if the patient has hyponatremia. Really be very mindful. Are you really sure you want to do that medication? Is it something that you can safely consider? Has this patient had multiple hospitalizations for hyponatremia? Maybe, the SSRI is something you want to really look at. Next list, US list of the FORTA, fit for the older adult. Now, there's 3 classifications as far as A, absolutely, fit for the older adult, have a good time, carry on. B, probably beneficial. And then C, be careful. So you can see here that SSRIs, especially, including like citalopram, escitalopram, you can use those in the usual doses, but be careful. Mirtazapine, again, be careful. And the SNRIs, your venlafaxine, your duloxetine, just be mindful of what you're doing. All right, deprescribing procedure. So how do you go at it? You're looking at this patient's list and they have 17 medications on there. Oh boy, where do you go from? Maybe you're just doing the Medicare annual wellness visit. So you're trying to look at this patient from the whole view. Maybe you just got this patient from someone who's no longer in your practice, new patient to you for whatever reason. All right, make sure you take a thorough history. Why are you on all these medications? What are they doing for the patient? Look at all of your medications and say, hey, are any of these eligible for deprescribing? Are there any of these that we can continue? Weigh the risks and the benefits. Get a good history from the family. What are their values? What are their values of treatment? What medications do they feel like really make a big impact on their quality of life versus what do they feel like is really taking away from their life, or a medication that they'd really feel like they'd be better off without. They tend to have patients in general, they have a good opinion. They usually, as far as they have a good sense of, very realistic very often, what is or is not actually benefiting them. Consider the costs, obviously. Every patient will tell you, I'd rather have the more expensive med taken off than the cheaper one. Like I said, talking about their goals. What are your goals for them? What's their family goals? Now, sometimes there can be some discrepancy. Daughter thinks that's really a helpful medication. Their spouse thinks it's really a helpful medication, and they disagree, or vice versa. They really think they need it, and the family thinks, this isn't really helping us out here. And then develop a plan overall. And it doesn't have to be done today, tomorrow, in the next week. Often, especially, things like benzodiazepines, you could have a very long-term plan to slowly take that medication off. What medication do you want to be on eventually? And then put the plan into action. And then just continue to monitor and revise at minimum during the Medicare annual wellness visit. Now, the Beers criteria. This is something that you hear about frequently as far as, why do you have to be cautious with a medication in your geriatric populations? You can notice specifically benzodiazepines are on the list, anticholinergics, I'll comment on that in a minute. Your antidepressants, they can increase your risk of falls. Benzodiazepines, you're also increasing your risk of fractures. Lithium, if you're dealing with bipolar, but that's beyond the scope of this. We actually thought about putting bipolar into this talk and then decided that bipolar depression and anxiety was way too much for one list. All right, this is more items on your Beers criteria. And then common medication interactions. Whoops. All right. This was also this was also addressed also in the talk yesterday, and then some of the herbals this morning during the depression and different types of treatments for that. Also applies in the geriatric population. So keep in mind, there's a decrease in the liver and the kidney of how well they're functioning. That increases your risk of interactions because it's just not getting out of the system. It's there longer to interact often if someone's older. So there's poor evidence for a lot of herbals, especially in geriatric people, which is, different types of populations. There is a lack of regulation in the supplement industry, so be careful of what you're prescribing and where your patients are getting it. Are they using a good quality company? Are they using one are they actually getting what they want in those supplements? You have to be mindful that some have significant medication interactions. So for example, St. John's wort. So it can interfere with your HIV antivirals. It can decrease your cyclosporin levels, worry about transplant rejections. Oral contraceptive pills, St. John's wort. Yeah, don't want an unintentional pregnancy there. So pay attention to that one in your reproductively active women. Warfarin, your antifungals. Digoxin is another one to watch. Narcotics. All of these. The EHR interaction warnings, those come up, and I know that I've done it personally. I've definitely seen some residents do it. It pops up and you click next and close it and move on with your day. And maybe we should be taking a couple more seconds to think about that. Easy thing to kind of ignore. You just get that notification fatigue. So paying attention, actually using the interaction warnings appropriately. Be aware of the medications that cause QT prolongation. And then your anticholinergics, which I'm actually going to address more here. All right. So this is the anticholinergic cognitive burden scale. So this is gives you a feel for what medications you have to watch, how at risk is your patient for cognitive effect by their anticholinergics. So the way this works is if you have a total score of 3 or more, you might want to consider eliminating meds. Now, the ones in score 1, that's a possible interaction, and 2 and 3 is either proven or highly suggestive in the research. So for example, if you have a patient who's already on paroxetine, you might want to be very cautious before you go to chlorthalidone for their hypertension, because they're already at risk for anticholinergic, and that would put that patient at a score of 4. So note on this list, you have your benzodiazepines, your SSRIs, your amitriptyline, olanzapine, risperidone, trazodone, Paxil, all on the list. Just be mindful of those. All right, non-medication treatment options. Absolutely, these should be going on in addition to your medication, and any good comprehensive plan for mood disorders. So you have different types of therapies. A lot of it's what works for that individual patient, what is the psychosocial needs that are contributing to their mood disorder, their depression, or their anxiety. A lot of different options there. It's also based on what resources do you have available to your patient in your clinic. So the CBT, interpersonal, behavioral, all of those different things. However, you do have to consider the values of your patients. So what have they tried in the past and has worked? Be ready to adjust for different cognitive or physical limitations. You might have to do more shorter visits if they struggle with stamina. If they have slowed thinking, make sure they're given the time to reflect, the time to think it through, that they're not feeling pressured. It may be a case of where are they comfortable. Obviously, huge interest right now as far as the pandemic access to psychotherapy services. How well can they concentrate, and also to what degree, how do you involve the family? What kind of dynamics are there that you have to think about? All right, it requires you to get quite creative there. Now there's other non-pharmacological treatments, including physical activity. This is a great one. They should all, everybody's capable of something. It doesn't have to be, hey, 96-year-old woman, you should really be running your first marathon this year. Probably not the best way to go about it, but every movement counts. All of your, anything you can do, whatever is reasonable for them, come up and work on. You can do prescriptions for them, movement prescriptions, exercise prescriptions. Find something that's manageable for them. You're never, it's never past a point where you won't benefit. Tai Chi is an excellent movement-based therapy to use. Chair yoga. Some people are very much up for standard yoga. Even you have to ask them where they're at. Bright light therapy is fabulous. There's a lot of research supporting it now. Typically, what I'll tell people to do is, ideally, when you read the research protocols, it's like 12 inches from your face, shining down on you. Don't stare bright and straight into the light because that's awful and sounds miserable. And start at 10 minutes, work your way up to 30 minutes as early in the morning as you can. Be careful, if they're bipolar, it can cause them to switch into mania. And if it's too late in the day, you can interfere with their sleep. And then there is new information coming out on the repetitive transcranial stimulation. So that's out there. All right, ECT, it is something to remember. It is out there. It is an option. It's something you can consider. Usually it's only really in hospitalized patients a lot of times, but severe or treatment-resistant depression, you want to see them have at least failed 2 medication trials. There's usually 6 to 12 treatments. May require maintenance treatments as you go along. There's a rapid response, so is the benefit, and an 80 to 90% response rate. It can be the treatment of choice for catatonia or psychotic depression. And then depression and dementia is a big deal. Both have depressed mood as a symptom, and they can often be very difficult to untangle. You really have to get a good history there. They share a lot of the same features. And so we have this lovely chart here. By the way, the citations are in the comments of the presentation that I uploaded to the Dropbox for the forum. So a lot of times your dementia will be more insidious. It'll be coming, you see it coming when, at least when you look retrospectively, maybe not in the moment. Whereas depression, a lot of times you can have a more rapid onset. You may have had depression in the symptoms in the past. So like, we know this, we've been here before. You can never really just dismiss without doing a thorough history, really figure out what's going on, one or the other. Be it, you tend to have consistent cognitive impairment is one of the big things. And in dementia, but depression, you may often have a history of depression. And then the way they answer the question can sometimes help you differentiate it. All right, team-based approach really is best if you can for your mood disorder patients, for all your geriatric patients if you can. I can't tell you the number of times that I have had one of my staff members say, hey, she isn't the same as she used to be when I remember her 2 years ago. And actually, it's interesting, in a residency clinic, a lot of times the staff has worked here longer than the residents. So they have a longer memory, so to speak, of these patients. They have a longer term relationship, and often they can tell them things. Hey, she wasn't always like this. This is a change. Like, she's never been snippy with me, and here she is. It's all based on who you have. Community agencies, we rely really hard on Aging Care Connections. I pretty much have one of the women over there. She's in my speed dial. Your pharmacist can help you out with your med lists. The patient's family can collaborate with them. Your behavioral health specialist, we use our psychologist quite frequently. He sees the patients with our residents. Your nurse educators, if you have them, especially in the hospital. So a variety of different ways to work with people. And then, partner with your patients and your family. There's a lot of dynamics to negotiate there, and be respectful of the patient's autonomy. That's something to kind of remember. They are the focus. Keep them in the focus. They're your primary goal that you really want to focus on there. And yeah. Any questions? Thank you. Our emails are here. I'm sorry, Sam, you didn't write your email up there yet. See. Anything that needs to be addressed in the comments, or are we good, Layne?
Not seeing any.
Okay. All right. If you have any questions, you have our emails here. We're happy to get back to you. And you all have a great day. Thank you. Julie. I can't hear you, Julie. You're muted.
Sorry, this was awesome. Thank you guys so much. I put links in the chat to your handout that you uploaded to Box. And I put the link to the evaluation up there. Everybody values the feedback that they get.
Thank you very much. Have a great day.
Have a good night. Everybody rest up tonight.
Thank you.
Bye-bye. Bye.
Bye.